I don't know how we're going to see our questions. Maybe you can can you see them on your phone?
Maybe.
Hi, everybody. Event logs?
So you're live now on.
Hi, guys. Welcome back to Fertility Factor Fiction. We're just spooling up as usual. We will have a blank camera for a second. We will be back with you in just a second. We are just getting everything set up. Welcome to the show again. And let us know if you've got sound on Instagram there for us and Facebook, please. So we always need some thumbs up if you've got sound on Facebook and Instagram. And we're just looking at the computer to see.
I don't know what's going on here. Thumbs up on Instagram. What about Facebook?
I don't know. Should we try the events log? Yeah, awesome. Thank you for letting us know. That's great. No events. All right. It's still saying
we're live. We did 3, 2, 1.
We are live. All right. I don't know.
Okay. I think we'll just go the old-fashioned way. I think it's working.
Okay. Okay, guys. So we're just getting set up. So do you want to set that one up, and then we're just trying to get our YouTube and. Well, thank you, Wendy, for telling us that there is sound. Big shout out to my wife, Wendy Victory, who absolutely hates being called out in public. So thank you for telling us that there is sound, Wendy. You are now infamous or famous. I'm not sure which one. Welcome back, everybody. And we're just getting everything set up. We will be on Facebook shortly as well. As soon as we have set that all up, we are good to go. You know what? Slide it right over because I don't need to see my, yeah. And then that way everybody's doing the same thing. You can tilt it towards me a bit. Yeah. Yeah, that should be okay. Okay, guys. I think we're live on Facebook now too. All right, good. So welcome back to Fertility Factor Fiction, where we spend at least about 10 or 15 minutes every week talking about really important, pertinent fertility topics that are hopefully of interest to all of you and help you through your journey. We know this journey is a difficult one, and we're here to help you out. We want to make sure you're getting all the information you can receive to make it as successful a journey that you can. We're not expecting you to do all your treatments with us. We just want to help you no matter who you're seeing or where you are. So don't hesitate to reach out to us regardless of who your doctor is or which center that you're using. So this week's topic is whether or not the Mediterranean diet can improve your chances of success when you're doing fertility care. So this is an interesting topic because if you go through social media and you explore what's out there, you will find that people like me who post interesting, or at least I think interesting information that is relevant to fertility care, frequently will receive a few likes, a few comments, maybe the odd share here and there. But if I go on there and I post something about natural ways to improve your fertility, instantaneously there are innumerable likes, comments, and shares with loads of people that want to get more information. So I thought this was kind of a pertinent topic because there have been a couple of studies out in the last few years. And very recently, just this month, there was one considered a seminal contribution, which is a really important contribution in the journal Fertility and Sterility that discusses whether or not the Mediterranean diet really is of benefit. So let's go through the studies and we can kind of have a look at each one. So starting in a journal called Reproductive Biology and Endocrinology, the authors there were Chinese authors, and this was a study conducted in China, and they had 590 women that they had on variable levels of a Mediterranean diet. So what is a Mediterranean diet? A Mediterranean diet is a diet that is low in red meat, saturated fats and sugar, and is high in things like fresh vegetables and fruits, nuts, and predominantly sort of a fish-based diet, although there is some poultry. So they scored people on the content of their diet and how Mediterranean it was, and then they looked at the outcomes. So in that study, they were doing what's called an observational prospective cohort. So they basically identified what diet you were on at the beginning, and then they followed you out during the time that you were going through fertility treatment to see how you would respond and how you would do, and then went back and analyzed it based on which group you were in, the low Mediterranean diet or the higher Mediterranean diet. So in that study, it was quite interesting. There were 590 patients, so they actually kind of followed quite a few people. And they showed that in the groups that had the higher adherence or compliance with the Mediterranean diet, there was a larger number of embryos, 8.4 versus 7.4, and this was statistically significant. So that's really just one embryo. Now, yes, everybody's saying, well, it's only one embryo, but sometimes all you need is that one extra embryo because you're really just looking for the embryos that are genetically normal. Remember, you need at least two because only about 50% of them will stick. So one embryo can actually mean the difference between success and failure. Now, they did mention that the clinical pregnancy rate, so again, seeing a heartbeat in the baby, and the implantation rates were similar between the two groups, but they ran a more advanced analysis and said that the number of fertilized eggs was higher and the embryo yield was higher when you were on this Mediterranean diet. So they didn't show an increase in live birth or clinical pregnancy rates, but they did show more embryos were created and that they saw more eggs being fertilized. So those are sort of at least the starting points to success, although we're not seeing the full success. So then there was another article where they actually tried to look at the live birth rates, and this is in Human Reproduction, which is sort of the major European fertility journal that we all use to study. So again, this is a prospective cohort, like I just described for you. And in this case, there were 244 women, but they were all non-obese between 22 to 41 years of age. And they were going their first IVF treatment at a center in Athens, Greece. So in this study, they compared women who had the lowest adherence to the Mediterranean diet to those who had the highest adherence to the Mediterranean diet, and actually showed very significant differences. So in the women who had the lowest versus the highest, the clinical pregnancy rate was 29.1% versus 50%. So a very substantial difference, a 21% difference in the clinical pregnancy rate between the two groups. And live birth was 26.6% in the group with low adherence compared to 48.8% in the group with the high adherence. So these are really important again. Now they looked at it a little bit further, and when they analyzed it further, they said this only was true in the women that were under the age of 35. Once you got over the age of 35, they didn't see as substantial or as meaningful a difference between the two groups. So age may be playing a factor here. We're getting into very sophisticated physiology because now you're dealing with how these nutritional aspects interact with your biology at a specific time in your body. And also keep in mind that we are focusing on a select group of patients. These are non-obese patients. Their BMI is relatively low. And they were definitely in the younger category in general, not in the sort of more advanced reproductive years. Most recently in Fertility and Sterility, which is the more major American journal that we use. Oh, we lost Facebook for some reason. Oh, it just came back on. It reconnected. In the most the most recent article, what we found was an article called Effect of a 6-Week Mediterranean Dietary Intervention on In Vitro Human Embryo Development. And it's called the Preconception Dietary Supplements in Assisted Reproduction Double-Blinded Randomized Controlled Trial. So this is a trial where they're actually applying the diet without people knowing whether or not they're getting the appropriate diet or not, and then checking to see if the actual outcomes were different. Now, they chose some kind of interesting outcomes. You would think they'd go for clinical pregnancy and live birth, which is sort of the hallmarks or the gold standard of all studies for us. They actually didn't. What they actually went into was how long it took to get to certain stages of embryo development and then something called a KIDS score, KIDS, which has to do with sort of time-lapse embryology, where you put all your embryos into this big incubator, and the incubator watches them with a video camera and gives you information about how the embryos are developing. Keep in mind, no one has yet proven that that technology is actually beneficial, but they are saying or suggesting that when you have certain features from that technology, it may lead to better embryo development and higher pregnancy rates. So in their results, what they actually tested were 111 couples, and 55 couples had the intervention. So this was only 6 weeks of a diet that had a lot of olive oil, including an olive oil-based margarine spread, a daily supplement drink that had extra omega-3 fatty acids and vitamin D, and we talk about vitamin D on the show all the time. So in that study, they compared the 55 versus 56 patients who were just on like a control diet where they weren't on those sort of supplements in the drinks. So, or at least the drink that they were receiving didn't have any of the enrichment in it. So in that, what they were able to eventually show is that a short period of dietary supplementation alters the rate of embryo cleavage. So they actually showed that more embryos were dividing faster, and that's an important marker in the quality of the embryo. They said that there was an increase in the KIDS score as well, and so they believe that there may be an improvement in the embryo quality, although it was only meeting criteria for a trend statistically, not true statistical significance. So we're not 100% sure about whether it impacts your actual embryo quality or not, but they are suggesting that it may. So overall, we have a bunch of information here, several studies which are suggesting that the Mediterranean diet can probably improve your fertilization. It'll likely improve your embryo quality, and maybe it is improving clinical pregnancy and live birth. So I further looked into this to see if there were any studies in relation to IUI. I could not identify any for those of you who are trying insemination, but obviously if it's working for IVF, then it will likely improve IUI as well. What you need to remember, and what's really, really important, is IUI does not have the same success rate as IVF, and so the percentages are going to be much, much smaller. So if this is going to provide us, just hypothetically, a 5% increase in our IVF success rate, you might be able to go from, let's say, 50 to 55%. With IUI, when you're dealing with a 10 or a 15% success rate, you're only going to see a smaller percentage just scaled down because it's not nearly as high as the IVF is. I also had several people on Instagram post asking about whether or not the keto diet was useful. So I did do a search for you all through PubMed, looking up the terms IVF and keto diet, infertility and keto diet, and actually there are no studies out there yet to talk about whether the keto diet specifically is beneficial for infertility or IVF cycles. Now, there are some important things to sort of give you as corollaries or sort of comments there. We know for sure that patients that lose weight, which is the main focus of the keto diet, do better when they're going through fertility treatment. And that study has been done, not specifically on a keto diet, but we know that if you lose weight, it will improve your chances of success. We also know that patients that carry extra weight can unfortunately harbor a lot more toxins, and so embryo quality, egg quality, miscarriage rates, all of these things are negatively influenced. So we know that losing weight and clearing those toxins from your system actually can have quite a significant impact on your success. So the keto diet has never been proven to be beneficial, but we know that weight loss is, and if the keto diet works for you, then for sure I think it's going to end up eventually providing you some benefit. It would be hard to not imagine or state that that is the case. So this week's Fact or Fiction: does a Mediterranean diet improve your fertility success rates? It is a fact that it does appear to improve your egg fertilization, your embryo development, and possibly your live birth rates and clinical pregnancy rates as well. So that's the topic for this week. I'd love to have you guys ask questions about that or comment on the topic. If you think it's important and you want us to talk about it more another time, we can always do that too. And of course, I'm always happy to bring on our amazing naturopath, Dr. Jen Strong. And we now have a nutritionist working with us as well. And they can come on and chat about how all of this affects your fertility as well. And we can bring them back on the show. Jennifer's been on with us before. And we'll look into bringing our nutritionist on as well. So I'm going to take some questions now. If you see me reaching for the screen, it's because I got to make the questions go by. So forgive me. And feel free to shoot out your questions for us if you have any for this week. Now is the time. Okay, we've got no one on Instagram, so let's go back to Facebook. Am I moving my offices in Sarnia? Well, we are sort of moving our offices in Sarnia, but very slightly. We're literally moving one door away. So for a couple of years now, we've been in the Mara Surgical Center and have been very happy to be working with them, but we've outgrown our space. The clinic is growing. And we wanted sort of a more private space with easier access and definitely more fertility related, equipment and furniture. So we are now going to be in our own center there and are very excited about that. That should be up and running in about a month. And we will be happy to have you guys there. We're just getting ready to do some minor renovations to move in. Very excited about the new clinic. It's spacious, it's large. We'll have 3D ultrasound there for you, including the obstetrical 3D ultrasounds. There will be a nutritionist there as well, and we're working to get a psychologist and a naturopath in that clinic space as well. So it should be another full-fledged Victory Reproductive Care location. And like I said, very excited about that. We are working alongside a pharmacy group as well to make sure we can provide you with the nutritional supplements that you want, as well as the medications that we need you to get. So yeah, we are moving in about a month. Hello to all of you that are saying hello. So hello right back at you. Okay, and someone had answered that. What about the keto diet? Hopefully we answered that too. At 31, do you think it's better to take a break from trying and lose some weight since my BMI is 34? Okay, so at 34, your BMI is certainly not in the range where we consider it unacceptable or dangerous, but it is in a range where we would ideally like to see the BMI come down a little bit lower. So with that in mind, I think it's reasonable to maybe do both in that circumstance. We would never stop anyone with a BMI of 34 from going ahead, but you will do better if you are able to get your BMI under 30, which can be easy for some people, and for others it's quite a challenge. So I'd actually say take a balanced approach and do both. Consider getting the exercise that you need, switching to a healthy diet, maybe the Mediterranean diet that we've mentioned here. Make sure you're eating under 1,500 calories a day and that you're doing that spaced out over the course of the day. So you should be having breakfast snack, lunch snack, dinner, or dinner snack. And make sure that those snacks are not things with high sugar content or high fat content at all. It should basically almost always be vegetables or fruits with low sugar content in them. And I would sort of continue doing those two things together. I think that would be very reasonable for you to do. Can you still seek treatment? Yeah. Yes, you can. Just make sure you come in and see us and we will help you as you're going through it for sure. Okay. Am I closing my Windsor facilities? No, we're definitely not closing our Windsor facilities just because we're moving in Sarnia. We are moving the office that we have in Sarnia, but we are keeping the Windsor facility. In fact, IVF will be up and running by the end of this month. So we are very excited about that. We'll start transferring embryos here soon. Very excited about that too. And yeah, we're very, very excited to have the Windsor facility up and running. Okay, what about Instagram? I read that fertility overall is now lower compared to previous generations. If this is true, what are some hypotheses? Well, that's a great question. So that is true. the rate of infertility is actually increasing. So if you look at studies from maybe 5-10 years ago, 15-20 years ago, the rates keep getting higher and higher. So originally, when I first trained, they used to tell us somewhere between about 7 to 10% of the patients out there were infertile, or the population was infertile. The most recent information is that it is somewhere between 13 to 15% as of right now. And if you look at prognostications, they think that the infertility rates will be close to 20% by the year 2030. So why is this? Okay, number one, no question, it is related to the fact that people are waiting longer. So the longer you wait in order to start your fertility, especially and definitely unfairly, as a woman, the harder it is to conceive, because we then start running into egg quality and embryo quality issues. Also true of a man. The older a man gets, the worse the quality of the sperm, but it actually takes quite some time for that to occur. It's not really until over the age of 50, 60 that we start seeing significant degradation in the sperm DNA quality. Number two, exposures. So smoking, drinking, drug use, environmental exposures, the plastics, the BPAs, all of these things can actually really negatively impact your fertility rates. And then number three, we live in a pretty stressed society. So these days, even in the youth, we have an enormous amount of anxiety, depression, stress, and these all have a negative impact on fertility as well. The more obvious ones are things like, there's much more sort of sexual promiscuity, and if not promiscuity, there's a lot more sexual freedom now. There are more people that are developing sexually transmitted diseases. All you need is one bout of chlamydia or gonorrhea. That can damage your fallopian tubes. It can block them. Same thing in a male. It can block your epididymis or your vas deferens and cause scarring that prevents the sperm from coming out. So there are a host of different reasons. BMI is one for sure. Somebody just asked about that. We do have a obesity epidemic worldwide, and in particular in North America. That has a huge impact on your success rates. And we will very shortly have our BMI function up on our website. It's like 7 or 8 pages worth of data on how it affects your fertility. So it's a worthwhile read. It's very scientific in some parts and very simple in others. We're going to have a short and a long version, so you can explore both if you want that. So yeah, there's a host of different reasons. Age is definitely number one. Other factors are things like exposures, both chemical and environmental, and then things like BMI and sexual function. So hopefully that answers that question for you. Okay, did I miss anything on Instagram? No, not there. Okay, one more Instagram one. What is the correlation between hormone therapy, IVF, and even just birth control and cancer? Is it true that you are at a higher risk of cancer after hormone treatment? That's a great question. Okay, so this has been asked before and I've answered it before, but I'll do it again. There is no question that patients who experience infertility are at a higher risk of cancer. So there was a study done out of Stanford, probably 20 something years ago now, where they had over 20,000, I think it was 26,000 patients. And in that study, they demonstrated that it was the diagnosis of infertility that actually led to higher risks of cancer. It was not the the fertility treatments. Now, this is a back and forth issue because every year somebody publishes a study saying, yes, it does increase the risks of cancer, and then somebody else publishes one saying that it does not. So to the best of our knowledge, there is no clear-cut data that suggests that the infertility treatments increase your risk of cancer. But the fertility diagnosis does. As an example, for all those of you who suffer with endometriosis, your risk of a very, very rare type of cancer is increased. I don't want anyone to panic. I've only seen this type of cancer once in my whole career. So it's not something we see often, but they are at about a 2.2-fold increased risk of that specific type of cancer. It's called clear cell cancer of the ovary. So yes, we know that patients with fertility issues have higher risks of cancer. PCOS is another good example. Women with PCOS who don't regulate or control their periods, and I'm sure you've all heard me kind of talk about that before, it's critical you keep your periods regular. They are at a markedly increased risk of endometrial hyperplasia, atypia, and then cancer. So cancer risk is more related to your diagnosis of infertility, not so much the treatment as far as we know. Now, there are hormone treatments which may increase cancer risk. That is when you're getting menopausal. If you are using menopausal hormone therapy and you are using a combination of estrogen and progestin, there is a belief, again, it's not 100% for sure, but there is some data and there is a belief that it does increase your risks. Some of that data is from the very poorly done Women's Health Initiative, and some is from a non-randomized controlled trial called the Million Women Study, which was a British study looking literally at 1 million women, over 1 million women. So both of those are really important seminal studies. Lots of people critique them both and go over the issues with them, but essentially there does appear to be an increased risk of breast cancer if you're using estrogen and progesterone in the menopausal years, not when you are premenopausal. Your question also asks about birth control. Birth control and pregnancy and delivery all drastically reduce your risks of ovarian and endometrial cancer. Pregnancy and birth also drastically reduce your risks of breast cancer, especially when you breastfeed. So overall, the likelihood is very high that you will have a lower risk of cancer from doing fertility treatment as long as you are successful. And that's really important to know. Okay, back to Instagram. What are my thoughts on acupuncture while doing fertility treatment? So Dr. Jennifer Strong, our naturopathic doctor, she does acupuncture for us. The data on acupuncture we've reviewed before. Maybe that would be a good fertility factor fiction. But the reality is we tell everybody it is highly, highly dependent on your stress level. So if doing the acupuncture relaxes you and you feel kind of more at ease and you're calmer when you're doing it, then for sure it's going to be of benefit to you. And conversely, if you get stressed and you hate the needles going in you, there are some people that are needle phobic or they're just irritated by it, then the reality is that those patients will probably do worse and certainly not better. So if you find acupuncture soothing, it's likely going to help. If you find it not soothing, I definitely wouldn't recommend doing it. Overall, there is evidence, scientific evidence, that acupuncture can affect things like blood flow. And if you are delivering more blood flow to the ovaries and to the uterus, theoretically, that should improve chances in general because it means more nutrients, more immune supply, more sugar, more oxygenation. So yeah, overall, it's probably not a bad thing. How long after a C-section should you wait between pregnancies? Oh, great question. Thank you for asking that. Okay, so some real basic information there. If you are going to have another C-section, 6 months minimum, and that's actually just to breastfeed your baby. So you don't need to wait longer than 6 months, but if you're waiting 6 months, that's kind of critical and important, and that will give you the best results you can ask for as far as the shortest time period while being safest for you and baby. If you want to try and deliver vaginally after you've had one previous cesarean section, then you need to wait a minimum of 9 months and much more preferably 15 months so that the total gap between baby to baby, or what we refer to as the interdelivery interval, is at least 2 years. And the reason for that is when we put the uterus together, we kind of sew the two open sides together, then we fold it down and we sew the ridge together again. It's called imbrication. So that imbrication is designed to try and strengthen the uterus so that in another pregnancy or another labor, there's no chance that it will pull apart. That's called a uterine rupture or dehiscence. There is a percentage chance of the uterus tearing when you are trying a trial of labor after a previous cesarean, and that's something we call TOLAC, for trial of labor after cesarean, or what used to be called a VBAC, which was a vaginal birth after cesarean. So that risk is about 1 per 200 unless you're getting extra medications like oxytocin, and never get misoprostol or prostaglandins if you've had a previous cesarean. The risk is 7-fold higher for that rupture risk, so that's not safe. So yeah, you can definitely wait a minimum of 6 months if you're going to have another section. If you didn't have the desire for another section, you want to try and deliver vaginally, ideally a minimum of 15 months between babies. What about 16-8? I don't know what that question means. Carolina, you asked about what about 16-8? I'm not quite sure what you mean by 16-8. If you can shed some light on that, that would be good. Okay, if I was to do the Mediterranean diet and not include fish, should I supplement with something else? Yeah, so supplement with the omega-3 fatty acids, which are the fish oils. And those are very helpful because that's the component that you're actually getting from the fish, which is helpful. Omega-3 fatty acids work through something called the PPAR pathway, and that's the peroxisome proliferator activated receptor pathway. Yes, that is a mouthful. And that has a huge impact on inflammatory cascades. I actually published a study in Fertility and Sterility years ago when I was a fellow, looking at the impact of the DHA, one of the components in the fish oils, on markers of inflammation that led to adhesion formation post-surgery, and showed that giving patients the DHA, or at least into the cell culture in our study, actually made a big difference. So we do want you to take the DHA. That's one way to get around the Mediterranean diet without actually having to eat fish. And actually in the study where they supplemented, they didn't supplement with fish. They actually supplemented with olive oil and a drink that had vitamin D and the omega-3 in it. So that's an easy workaround for those of you who are vegan or who are a vegetarian. Hopefully that addresses that. Okay, when doing saline-infused ultrasounds, what kind of problems can you find? Okay, so we have a great video on our YouTube channel, so subscribe please and throw up some likes there. It's from one of our amazing patients who was willing to allow us to live do a video of a saline infusion sonohystogram on her. So what we are looking for are several things. We're looking for how tight your cervix is, whether or not there's cervical stenosis. We're looking for whether your lining is a triple layer lining or you have a sort of an inhomogeneous lining. We're looking to see if you have polyps or fibroids inside the cavity of the uterus, because those can significantly reduce your success rates. We are looking for whether or not you have an abnormal shape to the uterus. So it can be a T shape, a Y shape. You can't see my other finger, that's retarded. Or it can be a bicornuate or septate. So you can see all of that if you have a 3D ultrasound. On top of that, we also look for the tubes and whether or not the tubes are open, whether or not they're swollen and filled with fluid. And we also look at the proximity of the ovaries and then whether or not there are any cysts or abnormal contents in the ovaries. So things like a fibroma, a simple cyst, a complex cyst, a leftover cyst, endometriomas, those sorts of things. So that's what we're learning from your saline infusion sonohystogram. What are my thoughts on tubal cannulation procedures? That's a great question. So a tubal cannulation procedure is where usually a radiologist will go in with a fluoroscopy, meaning they're injecting dye and doing x-rays, and they are going to pass a very long wire with a tiny little ball at the end. And they basically try and jam it through your tube and break any adhesions that are in the tube apart to try and reopen the tube. There are studies on this, and the success rates are around 40%. I've done it for 2 patients here. There used to be a lovely interventional radiologist here by the name of Dr. Jack Spears. Shout out to Jack. I'm sure you're not watching, but he was amazing at what he did. And he did it for 2 or 3 of our patients, and none of them conceived after we did that. So I'm not convinced it actually works on a regular basis. You really have to kind of be the ideal patient. And keep in mind that a big part of it is not just what's happening inside the tube, it's what's happening outside the tube, which we can't help. with just a recannulation procedure. So for example, if your ovary is here and your tube is stuck like way over somewhere else, you're not going to be able to get the tube to grab the egg from the ovary, even if the tube is open. And I usually refer to that as a functional obstruction. It may be open, or patent is the term we use, but it's not functional because it can't actually reach down to grab the egg. So I'm not a huge believer in them. Having said that, it's definitely cheaper than IVF. It's free under OHIP if you can find a radiologist who can do them. I heard recently that there may be a doctor at Sunnybrook that is capable of doing it. Again, I don't know what the success rates are. Are there any safe hair growing products for men that don't affect male fertility? No, nothing that works well, because the main one is Propecia, which blocks you from making testosterone, which actually can impact your sperm production. And I've had to take guys off of Propecia. Probably the best thing would maybe be Rogaine. I don't know of any studies that have looked at the relationship between Rogaine and sperm quality. That's something we'd have to look at. Good question. Thanks for asking that. If I was to do the Mediterranean, oh yeah, we already did that one, sorry. If you have a miscarriage, does that increase your risk for future miscarriages? Usually not one, but if you've had multiple miscarriages, more than 2, then yes, it does. So currently, the world guidelines for evaluation of recurrent miscarriage is actually after 2. It used to be 3, and now they've really moved it to 2. So if you've had 2 miscarriages in a row, then there is no reason why you should not get an exploration of what's going on, some blood testing, ultrasound, so on, and determine what is going on to try and prevent a 3rd miscarriage from occurring. So 1 miscarriage is actually, unfortunately, very common. 1 in 4 women will have experienced a miscarriage, and 1 in 6 to 1 in 8 pregnancies will actually end in miscarriage. So it is extremely common to suffer through a miscarriage. My heart goes out to all of you who've had to go through that. We know how hard it is, and we are here for you. So make sure you reach out to us if we can help you emotionally, psychologically when that happens, and medically as well, because there is help for a lot of women that go through miscarriages. There are ways to improve your chances so it doesn't happen. When taking Femara, that's Letrozole, to stimulate ovaries, are there any tests done during your cycle? It depends. So there is no evidence that monitoring a cycle with ultrasounds and blood work for just using Letrozole, for example, if you are PCO, actually improves your success rates. So it's not something we encourage patients to do. For those that really want to know what's happening with their ovaries, or if they are not responding to the Letrozole, then for sure you would want monitoring. But you don't actually need monitoring outside of an ovulation predictor kit. So if you are using an ovulation predictor kit and it is showing you a strong positive somewhere, between days, say 13 to 18 or so, then for sure you are, ovulating with the Letrozole, and therefore you don't really need to do any additional monitoring. However, for some patients, they need the reassurance, and that's what we're here for sometimes. So we will do it for those who need the reassurance for sure. Okay. If Letrozole didn't work for IUI, would you recommend FSH administration for unexplained infertility? Okay, so I would, although there was just a very, very recent this month article, and I'm trying to remember which journal it's in. I think it's actually in Fertility and Sterility, that suggests that for the treatment of unexplained infertility, the difference in success rates between Letrozole and injectable medications is so slim that it is not worth the very significant increase in the risk of multiples, meaning twins, triplets, quadruplets. I can't say that I am 100% in agreement. I think if you do a careful injectable cycle, you can still get a very reasonable success rate with a low rate of multiples. We definitely have had our share of multiples and high order multiples, but it really is pretty uncommon with our IUI program. We tend to do quite well. I will say that now that we have adopted the new Zymo, that's XYMOT microfluidic sperm sorting process for our IUI. Our IUI success rate has been the highest I've ever seen. Our recent average in our Sarnia clinic, where we've been having to do all of our IUIs for the last several months, is actually 33%. So we have done outstandingly well, and I really attribute a lot of that to the amazing staff we have down there. Thank you, ladies. You're all amazing, and James as well. But also for the microfluidic sperm sorting chamber. So this is basically a new device where you put the sperm on one end, you put some culture media on top of a disc. The sperm have to swim through this membrane, which is the disc, and then only the sperm with very low DNA fragmentation and high performance are able to get through. You then collect those on the other end of the chamber, and then you can use those, and it does seem to be making a big difference. So thank you to the folks at Zymo who produced that. I don't own stock or anything like that. They just make a hell of a good product. And we are trying to phase it in so that that's what we use for almost everybody. So in those circumstances, we may want to be even more careful with the injectables because we may end up with a higher chance of even higher order multiples, triplets, quadruplets, and so on. And obviously that's not a good thing. For those of you that think it's cute, it's not cute. The divorce rate with triplets is 150%. The divorce rate, even with twins, is 80%. We really try to avoid it. The pregnancy risks, the social risks are really quite significant. Okay. Let's see what else there is here. Can endometriosis affect your kidneys? I keep getting kidney and bladder infections, and I just know I have endometriosis. Well, I'm sorry that you're getting kidney and bladder infections. If it's implanted, okay, so let me back up for a second. Endometriosis can go anywhere. I had a classmate in med school that had it on her diaphragm. There are reports of people that have it in their brain and get monthly seizures around the time of their period. And I actually published a paper on umbilical endometriosis where it came to the surface of the umbilicus in the Journal of Minimally Invasive Gynecology many years ago. So it can go anywhere, and because it can go anywhere, it can definitely land on your kidneys as well. Now, it wouldn't cause infection, and it certainly wouldn't cause kidney or bladder infections, but it may be causing irritation, including blood, and it may then be predisposing you to the infections. So it's possible there would not be an easy way to figure it out short of someone going in laparoscopically and evaluating your kidney. Keep in mind that endometriosis can be very small little spots of cells. I'm not sure how easy it would be to see on your kidney. There is no diagnostic imaging technique like MRI or CT or anything that would show it. So great question, but it would be tough to figure out. On the bladder, however, there are many women that get endo on their bladder. And it's, again, not visible on ultrasound, but it's very easy to see laparoscopically. On our, it's on the Instagram, we have a video of me operating on endo, and a lot of the spots from that video are actually on the bladder where I'm burning or removing them. So endo on the bladder can feel like a bladder infection for sure. Can the Mediterranean diet help you lose weight? Yes, the Mediterranean diet can help you lose weight. So people who live in the Mediterranean region are actually much healthier than the rest of us are. They have lower rates of cancer, they're thinner, and they live longer. So that kind of mentality of an active lifestyle, which is one component of it, healthy diet, and low kind of stress lifestyle are definitely conducive to weight loss. So yes, it can help you lose weight, but it has to be part of a bigger sort of approach to things. Nick, my day was great. Thank you for asking how my day was. I did get slammed delivering 10 babies last night. So if I look tired, that's because it was a very long night helping people out. Okay. My youngest just asked me who I am, me meaning I am Rahi, and I said, you were my doctor and the first person to ever touch her, and she was amazed. Thank you. That's awesome. Thank you. Thank you for sharing that. That's really sweet. What an adorable thing to say. Thanks, guys. Is there a way to improve Improve egg quality? Yes. Okay, so egg quality depends mainly on age, but there are numerous things that can negatively impact egg quality. Now, keep in mind when we talk about egg quality, we are not talking about egg genetics. Whatever your egg genetics are, they are predetermined and we can't change them. But if we're talking about the quality and the function of the egg, vitamins, supplements, healthy dieting, getting the weight down, that's very critical. High BMI is known to cause problems with egg quality. So reducing weight, reducing stress, and on top of that, making sure that you are avoiding the cardinal sins of smoking, drinking, and drug use, including marijuana, are all very effective ways to improve your egg quality. So make sure that you are adhering to all of those things because it will have a very significant impact on your success. Okay. Am I still available for a visit in Toronto, or do we have to come to Windsor to see me? No, I will have a Toronto office by the end of this week. So I'll be announcing that very shortly. By next week's Fertility or Fact and Fiction, you'll know about the Toronto setup for us. We have a new office there, and I am just about to sign the contract, actually. So good question. Good evening. Can you talk about a woman with bicornuate uterus and what the risks of pregnancy are? Sure. So a bicornuate uterus, for those of you that don't know, is when the inside of the uterus is heart-shaped and the outside of the uterus is heart-shaped. So it's both inside and outside. It is not something that we can surgically correct. A septate uterus is when it's normal on the outside, indented on the inside, and that one we can surgically correct. The main risks are two things. It is known to increase preterm labor, so early delivery of children prior to term, which is 37 weeks of gestation. And it definitely increases the risks of having a breech presentation, meaning the baby would be bum down or back down instead of head down. There was a recent study about a year or two ago that actually said that it also increased the risks of miscarriage. Typically, we've always believed that the septate uterus increases the risks of miscarriage, not the bicornuate. But there has always been a concern that that indentation does not have the same degree of blood flow going to it that the rest of the walls of the uterus do, because it's too far away from the blood supply. And if there's less blood supply in the embryo implants there, it may not have the same chance of sticking and growing. So under those circumstances, it makes theoretical sense that there would be a higher risk of miscarriage. So hopefully the next question would then be, is there a way to correct that? So yes, you should always be vigilantly monitored with ultrasound to make sure that your cervix is not getting shorter. And you should be on progesterone through your entire pregnancy until you get to 37 weeks, because that has been proven to reduce the incidence of preterm labor. Never specifically in the bicornuate uterus group, but it does reduce risks of preterm labor in women at risk for preterm labor. It makes sense that it should be done in those patients too. Okay, let's go back to Facebook. Can you explain the process someone would take if they wanted to donate their eggs? Would they go to your clinic or contact a particular clinic to do so? Sure, you can contact us. We would probably put you in touch with our partners at Egg Helpers. They are an awesome group, although there are other fertility and egg donation groups, but we work mostly with Egg Helpers, and they are an amazing partnership with us. And so we would put you in touch with them. They would give you the details. I actually just did that recently for a young lady that was interested in information. And then they guide you through the process. We certainly are going to be providing egg donation services to our patients, but it's best for you to do it through an agency. And Egg Helpers is the one with the biggest infrastructure, the cleanest sort of setup, and they know what they're doing. So we've been very, very pleased with them every time. Excuse me. For women who have, oh, and by the way, if you're willing to donate your eggs, God bless you. That's awesome. The sort of impact and the meaning of that for somebody else's life is just beyond words. I cannot tell you how much it means to be a part of seeing the smiles and the tears when we deliver babies to couples that were not able to conceive on their own and then manage to have a baby. And that's all because of you. So thank you for doing that. That's amazing of you. For women who have PCO, polycystic ovarian syndrome, and trying to conceive, are there any blood work we should keep an eye on or be concerned about? Loads. Your insulin level, your glucose level, your vitamin D levels, your thyroid should be checked, your prolactin should be checked, your LH to FSH ratio should ideally be corrected. So all of those things are important. And if weight is an issue, we can't really test, at least in Canada, for your BPA levels, but it is an important part of fertility because we know patients that carry a lot of the BPAs, they have a higher risk of having miscarriages and poor egg quality. And you store that in your adipose tissue. So if weight's part of the problem, there is some advanced testing that would benefit you. Okay. I'm going to talk to my doctor to send me to see a doc for lap to be done. Oh, that was from our endometriosis question. Sure, no problem. Okay, have PCOS and started my period February 6th and after only mild spotting for normal length of time the past few months. Now I have been bleeding for 25 days, stopped a week ago for 3 days. What do you suggest? Going to my family physician ASAP. Yeah, you should. So first of all, do a pregnancy test, make sure you're not pregnant. If you are not pregnant, yeah, you need some blood tests. You probably need an ultrasound, make sure you don't have a cyst and figure out what's going on. With PCOS, remember, if you have not been regular, you've only been spotting, those are anovulatory cycles, and that can lead to overgrowth of the lining. That overgrowth can become precancerous or, God forbid, cancerous. You can never have PCOS and irregular cycles and not deal with it. You must be regular. Please, please, please. I say this in every show. Please be regular if you have PCOS. You either have to be regular naturally or you need to be on medication like the birth control pill or Letrozole in order to make you regular. So that's critical. How many units of vitamin D? 2,000 a day minimum, sometimes more, but try 2,000 a day. Do I treat women that are 45? My oldest patient at the Nahal fertility program that I just left is 62. We had ages of discussions. I told her I didn't necessarily think it was a great idea. She saw a psychologist. The psychologist said they felt very comfortable with her parenting. So yeah, I'm willing to take anybody as long as a psychologist at that age says it's okay. 45 is routine for us, so that does not require any kind of psychological evaluation. So yeah, absolutely, we would see you if you're 45, and we've helped loads of patients in that age group. I am 9 weeks. In my scan, there was a SCH, that's a subchorionic hemorrhage, which just means a bleed between the sac the baby's in and the wall of the uterus, of 1.82 in size. I'm assuming that's centimeters. Is this big? Should I be on bed rest? Will it affect the baby? No, it won't affect the baby. No, it's not big. Bed rest, if you're continuing to bleed, there's no proof that bed rest helps, but I certainly don't think people should be overactive. If you are not continuing to bleed, I wouldn't be on strict bed rest. Progesterone would definitely be a good idea. Make sure you're not on anything that increases your risks of bleeding like aspirin or heparin. And additionally, make sure that you're not doing anything where you're straining, heavy lifting, sort of high impact contact of any sort. But no, don't worry about it. It's very common. We don't get concerned. And as long as they saw a heartbeat, which they would have at 9 weeks, your risks of miscarriage are quite low, generally speaking, less than 2%. So you should be okay. I am about 7 weeks, no spotting, but I have moderate cramping and lower back pain. Is this concerning at all? I probably answer the same way I just did. So if they've seen a fetal heartbeat, no. The cramping can just be the stretching of the uterus. But if you're concerned, come and see your physician. Make sure they're doing an ultrasound and checking to make sure everything's okay, or serial beta HCG. Love watching your videos. Keep up the amazing work. Thank you. I appreciate that. And hopefully we are doing our best to help as many families out there. Love the work that you guys do too. Thank you for helping us with an amazing surrogacy program. That's absolutely awesome. Again, for the donors and the surrogates, your contribution and your sacrifice is incredible. So thank you for all you do. Would you treat a woman with IVF for over 40? Do you have an age cutoff? I do not have an age cutoff, but I do have a honesty problem where I have to be honest with you. So you have to sit down and do the math. So I'm happy to have that discussion with anyone. You need to know what the chances of success are for your age based on your body mass index, your age, your general health, what you've done in the past, and on top of that, whether or not you failed or succeeded in previous cycles, and then most importantly, how many eggs are you capable of making? If you're 40 and your ovaries are still really robust and strong, you still have a very good chance. And actually, our overall success rate in our 40 plus years has been very, very good. But if you look at national averages, whether it's from Carter, which is the Canadian registry, or from the SART, which is the American registry, success rates in that age group overall are relatively poor. So if you know what you're asking for and you're prepared for the outcome, yes, I'm totally prepared to help you, but I will never lie to you or sell you on doing IVF just so that we can make money. I will always be honest with you and literally work out the math with you so that you can figure out what your chances are. And if you feel comfortable trying with those chances, absolutely we will help you. But if you don't feel comfortable, then we'll help you find an alternative. So we never leave you, hanging or leave you in the lurch. We're always there to help you and guide you through it. And sometimes that's even just closure. Sometimes that's seeing our psychologists or our social worker. Sometimes that's hearing it from me. Whatever you guys need, we're there for you. Your age, your, race, your sexual orientation, none of that, whether you're single or married, we don't discriminate. We're here to help everybody. So whatever way we can help you, we will. Okay, I think we're winding down. It's not for me, but I had a friend who wanted to donate. I appreciate it. Oh, yes. Okay, great. Thank you for the nice comments. I appreciate that. How many days of bleeding or spotting of your first period after D&C is normal? At what point should I be concerned? If you're going on for more than like a week and it's painful and heavy, you should probably come and see me. So I would want to see you at that point. If it's within a week, you're probably okay. The first period after a D&C for a miscarriage can be quite heavy. So that's not abnormal or unusual, but we want to make sure no tissue is left behind. So for sure, give us a shout. I keep hearing people being put on metformin for PCOS. What irks me is that they believe it is an ovulation inducer, and it was explained to me that it is to treat the insulin resistance and doesn't induce ovulation. It doesn't make you ovulate, right? No, actually it can. So about 50% of women that start metformin and use enough of a dose can start spontaneously ovulating, but we don't actually use it to induce ovulation because it's not nearly as strong as Letrozole or even Clomid. So used in conjunction together, the Letrozole or Clomid with metformin, they're symbiotic. They work even better together than alone. But if you have to choose between metformin or Letrozole, you're definitely going to choose the Letrozole, not the metformin. But it is important to get your insulin levels secured and balanced because that actually impacts success rate as well. And there is some evidence to show it reduces miscarriage risks when you're controlling your insulin levels. So that's critical. Okay, we're winding down here, folks. So, had an ectopic pregnancy in October and miscarriage in December. Should I be on prescribed medication before pregnancy or only after conceiving? Oh, that's a tough question. I would need to see you and discuss the rest of your history with you. For just one miscarriage, I wouldn't worry about it. The ectopic, I would need to know why you had an ectopic. The only combination risk factor that would be sort of common to both would be smoking off the top of my head. So if you're a smoker, definitely stop smoking. But if you're not, then yeah, come in and see us and we'll figure out what's going on. Okay, last question. 27 years old, AMH 2.7, kind of freaking out. No kids yet, waiting for a consult. I will get you in. Are you waiting to see us, or if you're waiting to see somebody else? If your AMH is really low like that and we don't know it, give the office a call and tell them that your AMH is really low. I will make some extra time to see you. I'm a bit of a workaholic, which is why I'm still here post-call with no sleep. So I'm happy to see you. Staying 15 minutes extra for me if I can make someone's day brighter is fine. So get a hold of me or us and we will chat and figure it out. If you're somewhere else or in another community, either get to me or get to a doctor quickly. If that 2.7 picomoles at 27 years of age, that is concerning and you definitely need to rush. So make sure you do that. Okay, time to sign off. I'm sorry if I didn't answer your questions, but make sure